Welcome to another video. In this video, we will cover ischemic stroke on a CT. We will provide you with common signs and imaging findings every student needs to know. As always, we will aim to keep this video brief and focused throughout. Ischemic stroke is an acute neurological condition which causes impaired cerebral blood flow to our most vital organ. Just as in myocardial infarction, time here is tissue. Quick response, imaging and treatments are of the essence. Ischemic stroke is usually caused by embolism, which is dislodged into the intracranial arteries from another site in the body, often the heart or carotid arteries, secondary to atrial fibrillation or atherosclerotic plaque. Venous thromboembolism can also occur with right to left cardiac shunt through a patent foramen ovale or other defects. These are especially important etiologies to consider for young patients. Emboli can often affect the middle cerebral artery, but they can also affect multiple vascular territories simultaneously. Patients will present with sudden onset of focal neurological deficit, but the symptoms will depend on the vascular territory involved. Now let's have a look at the homunculus and connect the vascular territory to the symptoms. Most often, a large vessel occlusion will affect the middle cerebral artery. MCA stroke will usually present with a contralateral weakness and sensory loss, most prominent in the upper limbs and face. Cortical signs may include aphasia if left-sided or neglect if right-sided. Anterior cerebral artery stroke will present with contralateral weakness and sensory loss, more prominent in the lower limbs. Posterior cerebral artery stroke will usually present with visual disturbances. Lacunar strokes represent roughly a quarter of all ischemic strokes. Lacunar infarcts are usually small and symptoms will depend on the location and size, although many of these will go unnoticed. These are usually caused by lipohyalurosis secondary to chronic hypertension, and unlike the other subtypes, lacunar strokes will not present with cortical signs. Acute imaging in suspected ischemic stroke will vary between institutions. CT remains today the primary imaging modality. Most institutions will have a CT stroke protocol in place. These include a non-contour CT, CT angiogram, and CT perfusion. For the simplicity of this lecture, we will focus on the first two. Imaging starts with a non-enhanced CT scan, and it's important to rule out intracranial hemorrhage or other causes. We have another video for intracranial hemorrhage if you want to check that out. Once we have excluded intracranial bleed, we should focus our search on the suspected vascular territory, given that we are provided with the presenting symptoms of the patient. An important sign to look for is the hypotensive vessel sign. This sign refers to a focal increased attenuation of a vessel indicating a fresh clot. It's important to keep in mind that this appearance can be caused by increased hemoglobin levels, but that would be seen bilaterally, unlike the hypotensive vessel sign seen unilaterally. This sign is classically seen in the proximal segment of the MCA, and the easiest way to see it is to compare the vessel density to the contralateral site. This sign has a relatively good specificity but moderate sensitivity. For any suspicion of a hypotensive vessel sign, we should always compare this area to the CT angiogram to confirm our finding, but more on that later. Another important finding for ischemic strokes is the loss of gray-white matter differentiation. It is controversial of how early this sign will appear on a CT and will depend on individuals. Some patients may show ischemic changes early, so-called early progressors, and others will not, so-called late progressors. When blood supply is interrupted, the affected tissue will have a lack of oxygen and glucose, leading to the depletion of ATP. When ATP is depleted, the sodium-potassium pump stops working, which results in increased intracellular sodium and consequential osmotic influx of water. Since the density of water is 0 Hounsfield units, the density of the tissue drops down and the gray-white matter junction becomes unclear. This is called cytotoxic edema. In contrast to vasogenic edema, which is an extracellular accumulation of fluid secondary to blood-brain barrier dysfunction. Vasogenic edema will mainly involve the white matter, and the gray-white matter junction is often preserved. This appearance should raise your suspicion of a brain tumor or an abscess, as these can present in a similar fashion as ischemic stroke. When looking at suspected MCA infarcts, there are two important areas to focus your attention to. First, look at the deep nuclei of the brain and compare them to the contralateral side. This includes the caudate and the lentiform nuclei. These structures are supplied by the lenticular striate arteries, which are end arteries. Therefore, early parenchymal changes will be seen here. Another important area is the insular ribbon. Compared to the cortical areas, it is the furthest away from collateral blood supply. Therefore, early parenchymal changes are often noted here. When loss of gray-white matter differentiation is seen here, it is called the insular ribbon sign. A detailed review of a CT angiogram is beyond the scope of this video, as this is focused for students. However, we should take a brief look. CTA is an important modality to localize and confirm vessel occlusion. This study is also helpful to plan for surgery if mechanical thrombectomy is indicated. CTA is acquired as the vessels are opacified with contrast injected in the patient's vein. As the contrast reaches the intracranial arteries, they will appear white as they are filled with contrast. If any occlusion or thrombus is within the vessel, the thrombus will now appear dark compared to the contrast-filled arteries. In order to understand these images, it's good to revisit the circular villus and review in a simplified way on these axial CT images. We can divide the circulation into anterior and posterior circulation. The posterior circulation includes both vertebral arteries as they form the basilar artery. The basilar artery will bifurcate into the posterior cerebral arteries. The posterior communicating arteries connect the posterior and anterior circulations. The common carotid arteries will form the inflow of the anterior circulation. The common carotid artery will bifurcate into internal and external carotid artery. You can tell the difference between them since no branches will come off the internal carotid artery. As the internal carotid artery enters the skull, it will form the anterior and middle cerebral artery. Now let's apply these principles as we go through a case. Here we have a 65-year-old female presenting with a sudden right arm weakness and aphasia. Based on these clinical features alone, we should suspect an acute left MCA stroke. As we scroll through the case, we don't see any obvious hematoma or midline shift. The ventricles are normal and CSF filled. Next, we focus our search on the left MCA. We locate the vessel and compare to the right side. Here we can see that the left MCA is hypertense compared to the right, consistent with an acute emboli. Next, we focus our search for any signs of ischemic changes. First, we look at the deep nuclei. Here we can see the caudate nuclei are symmetric, but perhaps a bit unclear appearance of the left lentiform nucleus. We have a clear loss of gray-white matter along the left insular ribbon as early signs of ischemic stroke, as expected with our clinical history and hypertense MCA. CT angiogram shows an abrupt cutoff of the left MCA, confirming our diagnosis. This patient went for thrombectomy with successful restoration of blood flow in the left MCA. I hope you enjoyed this video. If you did, don't forget to like and subscribe. I hope I see you in the next one. Take care.